Welcome to KidzDocTalk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the Director of Telemedicine at Pediatric Associates.
Welcome to KidzDocTalk with Dr. Jennie. Today's guest is Dr. Jordan Steinberg talking about cleft and craniofacial surgery. Dr. Steinberg is a pediatric plastic, craniomaxillofacial, and orthognathic surgeon with the Division of Pediatric Plastic and Reconstructive Surgery at Nicklaus Children's Hospital. He currently serves as the surgical director of their Craniofacial Program. He earned his medical degree and a doctorate in neuroscience through the Medical Scientist Training Program at Johns Hopkins. He completed a residency in plastic surgery at Northwestern in Chicago, followed by a fellowship in pediatric craniofacial surgery at Children's Healthcare of Atlanta. His clinical interests include cleft lip and palate, congenital facial skeletal growth disorders and syndromes, craniosynostosis, ear anomalies, jaw deformities, and pediatric skin and soft tissue lesions. Welcome, Dr. Steinberg.
Hi, Dr. Steinberg. Welcome.
Thank you so much. Pleasure to be here.
Awesome. I'm excited to talk to you. This is the first time we've had somebody in your specialty on the podcast. So I have a lot of questions, and hopefully we can teach our listeners a little bit about the types of things that you take care of. So first, I guess maybe just start with telling me a little bit about what a pediatric craniofacial surgeon does and the types of conditions that you typically see.
Sure. Thanks so much again for having me. We are in craniofacial surgery sort of an offshoot of plastic surgery in general, and then also in many cases a branch of pediatric plastic surgery. So one of the things that really attracted me to this specialty when I was in medical school is just the great variety, and we always say, from head to toe and take care of problems all over the body, and then patients of diverse age ranges as well. But for those of us who take care of a lot of children or who work at a children's hospital, such as myself, there are a lot of conditions that are congenital in nature. So things like birthmarks, other birth anomalies such as cleft lip and palate, which we'll talk about a bit today, and then other let's say facial skeletal growth disorders or other things that then need the attention of a reconstructive surgeon. And so craniofacial surgery then is sort of a subset of pediatric plastic surgery, and one that tends to focus on head and neck and facial pathologies. And it's really been a great privilege for me to take care of children like this. It is quite unique, as you mentioned, and I think that we do have some things that are quite common. However, other things that are more rare, and that variety certainly makes it, really very, very interesting and rewarding.
So you mentioned that this is something that you became interested in like pretty early on in your training, that sounds like you were exposed to this in medical school. I think when people hear plastic surgery, they typically think like a cosmetic surgeon. So tell me a little bit about how like this kind of, career path came about.
Yes, thank you. And I would say that, that's a very excellent point, because we tend to hear in the media only about aesthetic or cosmetic surgery, and so many people, of course, equate the two. But really, our field is all about problem solving and innovation, and that's what attracted me to it. Unlike other areas of surgery where there are operations that get done over and over and over again, and let's say, maybe there's a little bit of variation from one to the next, but there really isn't this kind of scenario where you have to craft an individual solution for an individual patient. And so I was very intrigued by that. I did a dual degree program when I was in medical school, and I spent a lot of time in the lab. And so, this concept of having to really dig down and innovate to come up with an individual solution really appealed to me.
So let's talk a little about maybe one thing that I think people might be a little bit more familiar with in terms of some of the conditions that you face on a daily basis, cleft lip and palate. I think generally people have heard of this. And I think in my mind, at least as a general pediatrician, I equate cleft lip and palate almost always with, well, that just automatically needs surgery. And then those kids really do fine. Is that actually what happens? Is surgery the only answer? And is that a pretty, oversimplistic sort of explanation of what these kids go through?
Yes, thanks. So, I would say that, again, getting back to congenital issues or the pediatric plastic surgery part, again, we were talking about how, innovation and problem solving really defines our field. And I think for children, there are many problems, again, some of which are very common: dog bites, scars, things like this. And cleft lip and palate is not uncommon at all, actually. And this July, as we celebrate and recognize Cleft and Craniofacial Awareness Month, we talk about cleft lip and palate as being the second or third most common birth anomaly. And today, at the 20-week ultrasound, let's say for pregnant moms, we have very, very good reliability to be able to pick up a cleft lip, for example. So, we say 1 in every 700 or 1 in every 1,000 births may, be associated with a cleft. And so in a major metropolitan area, that's going to amount to a lot of children over the course of a year. And traditionally, again, we think of cleft lip and palate and the surgeries that are required, but there are many other elements of caring for those children in addition to just the procedures, let's say, that I do.
So that leads me to think that you probably have an opportunity to work with other specialists quite a bit. When I think of a multidisciplinary approach, especially for kids who might be medically complex or have craniofacial anomalies as maybe part of a larger syndrome, I always, try to find places for those patients in a multidisciplinary center. So can you maybe talk a little bit about whether or not that's something that you encounter and maybe other specialists that you work with when you take care of medically complex kids?
Yes, thank you. No, it's critical. It's absolutely critical. And multidisciplinary care is so important. What we want to do in cleft lip and palate and in a lot of other craniofacial conditions is to make for a sort of one-stop shop and to have the ability for parents to find all the specialty care that they need in one place. And so I work very, very closely with general pediatricians, with geneticists, with speech and language pathologists, audiologists, and then other surgical subspecialists, including ENT doctors and neurosurgeons. So all of us assemble together. And in fact, at our institution here in Miami, we have a weekly team that comes together to see about 12 or 13 patients, let's say, every week. And all of the specialties then have the opportunity to do the evaluation. And it really is something I think that provides great benefit.
What are some common conditions that you guys will see as a team or that may be referred to the multidisciplinary clinic like that?
So in addition to cleft lip and palate, we have infants with a condition called craniosynostosis, so where there's premature fusion of the skull bones, also a condition that very often requires surgical management. So we see kids with that. We see children who have what we call microtia, or having a malformed ear on one or both sides. That then goes along with other multidisciplinary care for the hearing aspects. We see patients with other facial skeletal growth disorders where there can be asymmetries in the facial development, or disorders of the nerves, the facial nerves. So there really is a pretty good range of things, but I would say that probably the most common is cleft lip and palate.
When you said craniosynostosis, my heart skipped a beat a little bit, because I think that's a fear every pediatrician has, right? Missing craniosynostosis. That's why we monitor the head circumference so carefully. And sometimes, craniosynostosis can mimic just, positional plagiocephaly, where, right, maybe the head is a little bit misshapen because of the time that the child spends just laying flat. And again, just something that we keep a very close eye on. Is craniosynostosis always treated surgically, or since they're now, you mentioned that it's a condition that gets referred to a multidisciplinary team, are there non-surgical approaches that can sometimes be appropriate?
Thanks. Yeah, I would say, one of the most common consultations that I do in this regard would be referrals from general pediatric practices where there's a question about head shape. And of course, today, by and large, the most frequent cause of having some abnormality in head shape would be positioning, and a lot of time spent on the back, as everyone well knows. This has made a significant improvement in the safety and the reduction of sudden infant death syndrome. But of course, we see a lot of children who have flattening in the back. But there are patterns, and what I tell all the families who come when there's a question about possible craniosynostosis or actual premature fusion of the skull bones, there are patterns we look for. And I would say that in about 95% of cases, in the literature supports this, we're able to look both with the physical examination and some factors of the history there, and be able to exclude or to make that diagnosis without having to resort to scans. But we're really looking for patterns there, and in some cases we do have this condition where we can identify those patterns and say that it has been premature fusion, and in those cases, generally speaking, we do have a recommendation for surgery. There are some exceptions and some less common types of craniosynostosis because there are different types, but in general, it does result typically in a recommendation for surgical management.
One of the things that I've sort of seen fall out of favor, both in the literature and both in practice, is the use of helmets when there's a concern for shape, head shape. Is that something that you see and recommend in either direction?
Yeah, so the helmets, cranial orthotic helmets, are very effective for positional plagiocephaly. I mean, our general approach here is that if infants are coming in and they fit a pattern for positional head shape changes, if they are at a younger age, meaning that they're coming to our attention, let's say less than 6 months old, we will often make a recommendation for what we would call conservative management, so that we're educating families on positioning. We're making a referral for physical therapy. We would like for at least half of the infants' waking hours to be off of the back of the head, and to minimize time in things like bouncers and swings and other devices that don't encourage the infants to use their muscles, because so often the head shape changes will go along with some delays in the muscle development and in the overall strength of the trunk and the neck. But if we have a situation either where things are quite severe from the beginning, or we're at a little bit of a later age where we've tried those things and we haven't had great improvements, then we will feel very comfortable to recommend a helmet for the positional head shape changes. And we've shown from studies a couple of years back now that the helmets can be 95% effective, and they really do work if fitted properly.
So are there any sort of going along the same line of maybe things that are used to help facilitate some of these conditions, any recent advancements or innovative techniques in your field that you would say have significantly improved either patient outcomes or surgical procedures?
I would. There really has been quite a revolution in our area of craniofacial surgery over the last decade with 3D printing and with the ability to plan cases on the computer. So, for example, for a lot of patients that require very complex surgical procedures to remodel the facial bones or the skull, let's say, we have the ability from CT scans to essentially do the procedure on the computer before we even enter the operating room. In some cases, this also results in what we call guides, or having devices that really enable us to very precisely line up where we're going to do those movements or those bone cuts, let's say, and be able to put things back together in a more predictable way. This is a time saver, and it's also a way, I think, to increase the accuracy. So that's, I would say, something that's really revolutionized craniofacial surgery. For infants with cleft lip and palate, there have been a lot of advances in these shaping or molding devices to help improve the form of the lip and the nose, again, before we even get to surgery. And some of that is also now being done with 3D printed molding devices. So it's quite exciting, and I think there have been a lot of changes.
That's fascinating. Do you ever have a diagnosis that when someone refers a patient to you, or that you see a patient for the first time and they have this diagnosis, it's like one that you feel like, oh, this is great. This is like, treated so well surgically, has fantastic outcomes. Like this is, if you're going to have anything, this is the one. Do you have any diagnosis like that?
Well, I always tell everybody I'm humbled by what I do every day, because, even if you take something that is more common, like cleft lip and palate. Again, no two clefts are exactly the same. There's a tremendous amount of planning and craftsmanship that goes into executing things exactly for that particular infant. In case I approach all infants and children as if they're my own child, and how are we going to get the best outcome we can. We always say we want a result that's going to stand up for 100 years. Ideally, we would do one procedure and not have any additional ones, but we know that isn't always the case. And certainly there are things that are maybe a little bit more routine and straightforward, but that then ranges, let's say, even to the very next patient or the next day, where there's something incredibly rare and we have to consult colleagues or look at the books or talk to the experts and figure out how we're going to to do this one. So it's humbling.
So obviously taking care of kids and certainly operating on children takes a tremendous amount of sensitivity. And obviously we know our patients present a unique challenge to us. They can't necessarily always tell us what's wrong. So how do you balance the emotional and psychological needs of young patients and their families with, giving them their medical and surgical care that they need?
Yeah, this is a good question. And I think that, in some cases, we do have a little flexibility, let's say, on the age at which we do a procedure. In other cases, we don't. And I think there's an interesting discussion that always comes up about, patient assent and, making decisions for your children. For example, I think we all feel very clearly that if an infant comes in and even has a more minor form of cleft lip, that because of the social consequences of that later on, that we're all going to make a decision to do that repair in infancy, and we speak on behalf of the child when we're signing up for that procedure. But when it comes to, let's say, a case with a small ear on one side, microtia, we will often, because there's not the same urgency, wait until the child is older and able to express an opinion. Do they really want to proceed with this surgery? And there are a lot of interesting things that come up, I think, with those discussions. But this is also why, when we have the multidisciplinary care, psychology is a very, very important discipline in our team. We want to have the input from the kids themselves. We want to have the parents. We want to take all these factors into account. And just as you say, to balance things so that we know that we're approaching things in a in a comprehensive manner, and one that is really respecting all of these issues. And sometimes it's not so simple. We may be presented as physicians with a scenario where a parent may be very much in favor of doing something and the child is not, but then we're evaluating down the road, is he or she going to regret that? And so we're in a interesting position of trying to evaluate, let's say, not only for the short term but for the long term, what is going to be a fair balance of all of those factors.
That resonates with me a lot, and I think that's something that anyone who takes care of kids struggles with. Certainly, as a general pediatrician, this stuff comes up almost daily, right? Even when we talk about things like vaccines, when we see babies, the risk benefit to me of vaccinating a baby against something that's potentially deadly, very straightforward. So I feel very comfortable making that decision, with the parent for the child. And then when the kids get older, and then we start talking about vaccinating kids when they're older against diseases that they're more susceptible to when they're teenagers and maybe even adults, and then there's hesitation, not necessarily from the parent but from the child themselves. I find that it's really important for me to get their buy-in, not necessarily just go through with it because the parent is supportive. And it sounds like that's something that you guys also consider, especially when dealing with things that aren't necessarily as time sensitive or urgent to operate on.
No, I think it does make a big difference too when the child has sort of bought into the procedure and we know that they're invested in their own recovery.
For sure. So I used to work as a hospital pediatrician, and I always used to tell people, like, if you don't know me, if you haven't met me, that's a good thing. It means your child hasn't needed to be in the hospital. So I imagine sometimes you tell people something similar, but is there anything that you would want families or caregivers to know, either about your specialty or about any of the procedures that you do?
Well, just along those lines, I do get that from time to time, but I also remind people that, even common things, for example, like dog bites and scar revisions and things like this, everybody will see. And so, again, I think some of the beauty of our specialty is that we are here to help. There are a lot of things that we take care of from the common to the rare, but, plastic surgery was sometimes in the past called, or we were called the surgeon's surgeon. And it's the concept that we don't have a particular body part or a particular location, but we're here to try to assist with lots of different things. And I think if there is something, please do call upon us. And we're always here to support the community.
Amazing. Well, I want to thank you again. Thank you so much for coming and speaking to me and sharing some of the amazing work that you're doing with your craniofacial team.
Thank you so much.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on KidzDocTalk.